Hello, I'm Jared Weiss. I'm a professor of medicine and section chief of thoracic and head and neck oncology at UNC's Lineberger Comprehensive Cancer Center, as well as a volunteer and executive board member here at Grace. And it's a privilege to talk to you today about screening for head and neck cancer. We know that we have screening for a number of other common cancers, such as breast cancer, colorectal cancer, and lung cancer, and that these save lives. And so our subject today is, what do we know about screening for head and neck cancer? And can I advance a slide? Here we go. So let's start by making sure we're all on the same page about our subject, head and neck cancer. There are a lot of cancers that can occur in the head and neck region, but when the term head and neck cancer is used, what we're really referring to are cancers, are squamous cancers of the respiratory epithelium. In slightly plainer English, we're talking about cancers of the mouth, including the hard and soft palate, of the oral tongue, meaning the tongue as we normally think about it. The base of the tongue, which is the tongue way further back than most people realize that it goes, the tonsils, the hypopharynx, which is right above your voice box, the larynx, which is your voice box. These cancers historically were mostly driven by smoking. In addition, oral cancers were driven sometimes by chewing tobacco. Still, that's one of the most common causes worldwide. But now we have a rising epidemic of HPV-driven cancers. These are the same high-risk HPV viral strains that cause cervical cancer, as well as other cancers. And they're biologically distinct. They present a little bit differently. And most critically, they're a bit easier to cure. That epidemic is still rising and will be for at least another 10 or 15 years, depending on uptake rates for vaccination, and we'll get to that. Other risk factors, heavy alcohol intake, and I do mean very heavy. And in India, betel nut chewing causes a lot of oral cancer. Patients with a history of head and neck cancer are forever at risk of a second primary. And what I mean by a second primary is not the old cancer coming back, but rather a totally new cell going bad and becoming a different cancer. We actually have found out in recent years that a lot of what we once called recurrences of a cancer were actually a totally new cancer. And this is particularly so in patients whose cancer is smoking driven. There's this thing called field cancerization. I think of it like darts, like a bullseye, darts with concentric circles, although they're not actually circles. You smoke some and you get a bunch of cells with one mutation. Keep smoking, some cells get a second mutation. Keep smoking more, some get a third. And through a combination of environmental carcinogens, ongoing smoking, or plain bad luck, cells sometimes make mistakes. Finally, one cell gets enough mutations to go bad and becomes a cancer. That cancer gets cured. But the problem is all of those cells that were one or two mutations short of cancer are still there. And even if you quit the risk factor, you can still have one more mistake go and flip a cell over. And so screening is particularly important for patients with this history, particularly smoking-driven history, who are at high risk. Leukoplakia is a risk factor, as well as the rarer syndromes of Fanconi anemia, Lee-Fraumeni, and Plummer-Vinson.